Hi, my name is Dan Gomez, and this is Mental Health Super Omnia. Mental health above all. We identify and understand mental health issues and the paths for help. According to the NIH, approximately 9.5% of American adults ages 18 and over will suffer from a depressive illness. That's major depression, bipolar, or, and I'll get the pronunciation wrong so you two can help me out, dysthymia each year. Women, it turns out, are twice as likely to suffer from major depression than men, but in bipolar, it apparently is equal. Typically, that major depression, although it can happen at any age, usually comes on in the mid-20s. Okay, same with bipolar, by the way. All the major depressions are in the mid-20s. To better understand bipolar, major depression, etc. We wanted to bring in Dr. Dara Abraham. Dara is a board certified psychiatrist, has done an incredible amount of work both in ADHD and in bipolar. And I'd like to ask you a question first, Dara. You actually did do a lot of work at ADHD, and now you're doing bipolar. What caused you to um, to start to shift or to see the importance of bipolar in your work?
Yeah, I mean, it's a great question. I'm still, very much involved in the ADHD world and still consider myself, fully immersed in that, patient population. Although what I realized is that a lot of folks who I thought had ADHD or just had ADHD actually had something else. And just like when I first went about diagnosing or fully getting immersed in the ADHD world, it was when a lot of folks were coming in with depression or not being motivated or anxious. And I realized that there was something else then. And that's what brought me into the ADHD spectrum. So then with this, I realized, the meds for ADHD are not enough. And they're still feeling not motivated, still having cycling periods where their meds, their stimulants, their Adderall, their Vyvanse is working, and other months when it's not. And so I started to say, hey, what's going on here? And that's when I did a deep dive and realized there was more to it. And I realized that not everyone with an underlying mood disorder, an underlying anxiety disorder presents the same way. And most adults do not exist. Most adults do not just have one disorder. Unfortunately, it's not that easy, and we're complicated creatures for a reason. And someone usually has a ADHD plus possibly another disorder. And a lot of times it is this, what I call mood spectrum, what others call bipolar spectrum. And so it really made me realize once I treat that underlying mood disorder, their ADHD treatment is so much more effective. And that is why I got there.
Interesting. And Erika, let's bring in Erika Kawamura. She's the Director of Strategic Initiatives for Equilibria Psychological. She has a doctor in psychology, a PsyD, years of experience, also board certified in lifestyle medicine. Erika, when we were talking earlier, you also mentioned the fact that that it appeared that some people would say that they have one particular type of a mood disorder, but then they had others, or that they had a different one because it was misdiagnosed. Do therapists see a lot of mood disorders in just their general work?
Oh yeah. And a lot of times, and Dara, I'm not sure if you heard about the recent study that came up with where they showed the neuroimaging of the three types of ADHD. And I'm like, yeah, of course, it's been around forever, the three types, but they were talking about the combined type with, emotion along with the emotion dysregulation, where it pretty much confirmed each of the diagnoses from a neurological level. And what I found fascinating about that one was when it showed that combined with the emotion dysregulation, all of these neurotransmitters were all imbalanced. And so I was like, oh my God, I know exactly the type that we're talking about, where it's just like really hard to treat. And then you wonder like that, is it really hyperactive impulsive, or are we looking at more of the hypomania? And sometimes when you do like that deeper dive, sometimes it's both. Sometimes it's one, sometimes it's another, or sometimes it's a much even milder one called like cyclothymia or, bipolar 2. So it's a lot of, parsing out, I feel.
It really is.
Mm-hmm.
And what I've noticed even is that, what I have come to really learn, since this is not something I learned in residency training, psychiatry residency, is that really that the emotional dysregulation that most of us didn't even know about is part of a lot of adult diagnoses, but also children and adolescents that comes with ADHD is well treated by ADHD medications. So the right stimulant, the right therapy really will help that emotional dysregulation component of ADHD, but it won't necessarily help the mood instability. And so if we treat it optimally with the right meds and right therapy, and we're still left with some sort of dysregulation that cycles that isn't constant, we're thinking more of the mood variability disorder. If it's actually the emotional dysregulation is actually constant, it's always there, it's not provoked, and it doesn't cycle, then we're really thinking, hey, is this more of just the ADHD?
So what bothers me when as I was researching this and as part of the overall discussion, if I have a mood disorder,
Yes.
what is it that I'm feeling? What is it that I'm feeling, number one? Number two, is anybody else seeing this in me? And how do I get help?
Such a good question. A lot of times, sometimes it is really clear and you just feel depressed and you actually can describe that emotion of depression or I have lost interest in things, which are the two things we look for when someone has the two main symptoms would be my mood is depressed or I've lost interest, which the term is anhedonia, which is that the jargon for I've lost interest in the things I used to like. But a lot other times, what we're looking for is more of the non-mood or non-interest things. And that's really shifts in someone's energy and motivation, in their irritability, in sleep patterns, and also in their level of like stimulation. And the pattern of this, is this something that's really happening over time? And so it's really hard to notice that in yourself, especially if you also have comorbid ADHD, we're really not that great at kind of remembering what happened, earlier that day, let alone, watching over a period of time. So, and also it's very subtle. These are not, when I say mood disorder, I'm not talking about what people think of as bipolar type 1, where you're actually having mania, where you're euphoric or extremely not yourself or manic. That's not at all what I'm talking about in the classic sense of bipolar. This is very, very different. And so it's not something that's picked up easily. Oh, sorry about that. Turn that. And so, yeah, it's definitely something that you really would need others to really pay attention to. And
when you say others,
your family members.
Your family members, that's what I was wondering. Okay. All right. So, you've mentioned bipolar, or we've mentioned bipolar a couple of times, and I think there's a documentary that's literally about to be released on, I think it's called Brainstorm. Could you tell us a little bit about that?
Yeah, so it is basically based on a woman's life who the documentary is based on her life and about her journey with bipolar spectrum and bipolar type 2. And that is just a little bit, there's a whole spectrum of bipolarity and, bipolar 1, bipolar 2. Then we have more of the cyclothymia. And then where I'm getting to more of this real spectrum where there's maybe just more of the depression with irritability, anxiety, activation, insomnia. And really, she wrote a book about her life. And when she was diagnosed, she was in undergrad and she was going to go on to medical school and her brain just stopped working. And it kind of was abrupt and she never had depression before. But if you look back at her family history, her whole family, mother, maternal grandmother. And so, but now the documentary is about really not, it's more based on true individuals that are living with bipolar disorder. Some of them are actually well-known individuals, some slightly, famous folks, and then also the scientists studying the disorder and how it really is a spectrum. And the goal is the goal is to reduce the stigma around bipolarity and to really show that this is not what people think it is. There really was once a time when ADHD had such a stigma and depression had such a stigma. I mean, and these days I have to say, anytime I bring up the medications that you use to treat bipolar, like mood stabilizers, most of my patients are scared. And so we really want to reduce that. And so that's the goal of this, is to get the word out that a diagnosis of bipolar spectrum or bipolarity is not a death sentence. It's the best thing that can happen if you've been living with depression for 5 to 10 years or some sort of, really interfering type of psychiatric symptoms, some set of symptoms that you just can't get better. There could be another reason. The diagnosis may not be inaccurate, but it may not be complete.
Erika, when I think about stigmas, sometimes people don't understand. So for example, cirrhosis, right? If I said, my wife has, well, she does not. So let's not use somebody specific. A friend has cirrhosis. Okay, immediately people would immediately think, my friend must be an alcoholic. Okay, and because they're an alcoholic, because they've abused alcohol, they're deficient in some way, deficient relative to me, and so there's a stigma associated with that. Now it turns out to be wrong, because just under 50% of all cirrhosis is actually caused by fatty liver. It used to be called
like not the
non-fatty, MASH, right?
Non-alcoholic,
non-alcoholic,
liver.
exactly. So, and it's just under 50%. So it's almost equal at this point in time. And as younger people continue to drink less, it'll actually flip. And so we'll have cirrhosis because people have fatty liver. So what's my point? My point is that there's a stigma, because in this particular case, because people have made assumptions about someone's inability to control alcohol. In this particular case, though, with ADHD or with bipolar, what's the stigma? Why is there a stigma associated with that? Is it because they're acting differently? Is it because they aren't doing things, or they're somehow they don't look different than me? So it can't be that. What's the stigma about?
Well, I think it's, it just goes to the general stigma with like mental health in general. You hear a lot of, these celebrities and well-known people just coming out with, I've got depression, I've got bipolar, substance abuse, alcohol, etc. But I think it's a lot of these people live with shame. Some people find relief from their diagnoses of like, oh my God, like I knew something was wrong with me and no one understood. And now there's finally a name for it, and but other times, they're living with the shame of feeling like different, or feeling they have to work harder, feeling like there's something wrong with them, or feeling like, people call them quote unquote crazy, or in the ADHD sense, like lazy, or, so, yeah.
Okay. I can see, once you use a word like crazy, I can see where all of a sudden someone would associate a stigma associated with that. So that makes a lot of sense. So as we talked about the NIH statistics, it looked like in major depressive episodes, it tended to be more women than men. Is there a reason for that, Dara?
That there was more women than men? That's a great question. And I don't really know the answer in terms of the statistics of the whole of why. I don't know. In your practice,
do you see more women than men?
Well, I do, but that is, I just happen to see more women because I just tailor my practice to adult women who have late diagnoses, and also women with hormonal impacts. So
Okay.
yeah.
Well, actually, since you did mention the hormonal impacts, can you speak to us a little bit about that? Because earlier too, when you had said, I forget if it was Dan or Dara, you said it, but something about like, oh, maybe it was you when you said the shifting in the mood, cycles every month and et cetera. And I think in one of your articles that you had written, it talked about the, at least for ADHD, the medication's not as effective at certain times of the month because of the hormonal impacts and everything. So can you speak to us a little bit about that?
Yeah, about the
Hormonal.
So I mean, for ADHD, especially the hormones, I mean, overall hormones are so important. Hormones, to just cut down to just to make it really simple, hormones, sex hormones, which are testosterone, which females have both testosterone and estrogen and progesterone. So females and males have all of them, but we have females mostly have predominantly estrogen and progesterone, but then there's still testosterone. And this is biological females. I'm excluding, transgender just for the reason of this podcast. But in terms of the, what happens is these sex hormones come in and they actually act like, during certain times of the month, they act like neurotransmitters. So they act like serotonin, they act like dopamine, they act like those chemicals that affect how we feel, how we think, our energy. And so what they do is they basically they're very different. And that's why they can affect our mood, our energy, our focus, fogginess. And usually during let's just say a woman who has what's called premenstrual dysphoric disorder, which is basically, I call it PMS on steroids, every month, the progesterone goes down every month after they ovulate. And what happens is they have less progesterone than they have overall in relation to the estrogen, the imbalance. And so what happened is they get much more moody and much more irritable and can become even depressed before their menses, their menstruation. And so the reason that we need to know this is that the reason is that hormone imbalance has affected what has usually worked for them. And so maybe they're on an antidepressant and it usually works all the whole month. It stops working as well. And what also happens, they start to notice, I'm foggy. I can't focus. My stimulant, my Adderall, my Vyvanse is no longer working. Well, that dopamine also is being affected. So the serotonin, which is the premenstrual dysphoric disorder, that PMS on steroids, as well as the ADHD. So both the dopamine and the serotonin are inversely affected. And so what happens is this all gets, and so we know, hey, our meds don't work. But then this also translates to the bipolar spectrum. What we do know is that one of the risk factors for having a cyclical mood disorder is having earlier times in your life of being affected by hormonal changes. So I don't want to, not everyone who has PMDD, premenstrual dysphoric disorder, or postpartum depression has a bipolarity. That's not what I'm saying at all. But if you are someone who has had a history of hormonal fluctuations that affect your mental health, and you still are suffering from episodes of depression that come and go and fluctuate with your energy and your sleep and anxiety, that could be something to look into, since hormonal changes can also, run with the mood spectrum.
Wow. So there's just a lot of impacts, a lot of things that you have to try and uncover.
Yeah. And then I'm just thinking like perimenopause, menopause, and you had mentioned the postpartum and postpartum induced, I think, rage or bipolar you had mentioned. And then what.
And I think the hardest thing is this isn't always a fun conversation, I have to say, because I almost sometimes, to be quite honest, want to ignore it, because sometimes I'd rather just go ahead and treat the thing that they came in to see me for, which is the ADHD. And when I can, I will, to be quite honest, because if I can and I can get their buy-in, and I'm not going to hurt them, but and I know there's some sort of ADHD there, because usually there is still something. And I know that by prescribing them a med for the ADHD and them getting into, like coping, like ADHD coaching or therapy, and we work on that, and it's not going to destabilize them, meaning I don't feel that they're going to become grossly manic. Then later, when they notice that, hey, I'm still cycling, my mood is still not where I want to be, my energy is not still where I want to be, then they're more likely to collaborate on the treatment and agree to maybe try that mood stabilizer, maybe the Lamictal that I had mentioned earlier. Otherwise, I get a lot of pushback, and it's not going to work for either of us. But it's a hard conversation, especially since, as you were talking about stigma, I think that what it comes down to is that, the fear of, am I crazy? Usually the stuff runs in families. You hear bipolar, am I going to be like my Uncle Joe, who has never had a life for himself? He's always, been really the odd one in the family. And the answer is really no. Just by you questioning that, by even having that question, you have more insight.
Yeah.
Oh, yes.
I watched the trailer for Brainstorm.
Yeah.
And in the trailer, there was one woman who had been diagnosed, and she was talking about her life just a little bit. And one of the things that she said is that she always viewed her symptoms as a superpower. So as opposed to the person that you mentioned that originally wrote the book, or that wrote the book, where she just felt like totally depressed, couldn't do anything at a certain point in time. This other person felt like she had a superpower. What does that mean? What are they hyper focused, or what causes somebody to see this as a possible benefit?
I mean, so it really, what happens is that a lot of the time, especially the spectrum, you never reach that point of what's true mania. And so when you are what we call either hypomanic, which is not depressed, but not really manic, where you're so grossly not yourself, meaning you could become, really dangerous, psychotic, you could be spending all your money kind of going off the deep end. When you're hypomanic or above your normal state, so you're just maybe more energized, have more energy, more activated, don't need as much sleep, you actually get more done. You actually are more alert, you're more elevated, but you're not at that point of mania where you're so alert and so activated that you're spending all your money, that you're kind of having affairs, that you're just not doing things, that you're reckless. When you're too reckless, that's where we get into trouble. But when you're just risk of, when you're taking enough risk where it's getting you what you need and what you want, and really kind of, focused, and you don't need as much sleep, that's actually when things could go well. And you actually would never come to see me unless it didn't flip into the depression. So I usually don't have folks come see me when they're hypomanic, or even around like even activated, or just they usually come see me when they're in the depressed state. And that's usually the case, or what's called a mixed state, which is really, I think, something that really needs to be understood, which is whether they have the depression and the anxiety and that activation, which is probably one of the worst states to be in.
Yeah, I can understand that, because I see, a lot of people are like, almost like, some people have even expressed like they're afraid to get depressed, or they're afraid of their depression. So those that hypomanic state that you're talking about, they like that, or like they think that it might be like their baseline, or I feel better, and oh my God, I'm not, I have more energy, I get more productive, and they actually like that hypomanic state, or they feel like they can function. And it's hard to parse out, like, whether is it like you're like a healthy, baseline normal quote unquote, or is this the hypomanic,
it's so hard. And I have to, like, that's where the collateral, like, are they always been like this? And even if they've always been like this, their family members usually have been like that too. And that's where the whole, family history.
Right, like my son doesn't have ADHD because I don't have ADHD.
Yeah, exactly. No idea. And these two disorders are bipolar spectrum bipolar disorder is the most heritable disorder we have in psychiatry. So yes, I think that it is. I think a lot of people would say that it is a superpower, and even Sarah Shatley, the author of the book Brainstorm, when I described that she had this period in her life, I think in college, where she felt like her brain broke. Before that, or I think it was, after that, she went on, was a very successful consultant, very brilliant woman. She has been a very high functioning woman throughout her life. So I think most people that I've seen and most of my patients who have some sort of bipolar spectrum are not what you think. They're my CEOs of companies. They're my very, high functioning, like really smart, creative. They're, I do look at them a lot like, wow, like, that's such a brilliant idea. Like, we just got to get you stable and get you on the right mix of meds. So I never have to really, have to have you not be as great as you are right now.
So, Erika, you brought up an interesting point. If the family has ADHD, they think that's normal and they wouldn't recognize it in their family member. So how are people, if there's going to be an intervention from the outside, how do they get that? How do they get help? How do they know to get help? Particularly,
are you talking about ADHD? Are you talking about ADHD? Or are you talking about mood disorder?
Well,
or both.
Both, actually, yeah.
Mm-hmm. Are you asking like, how do they know to get help, or how do the outside
people know?
No.
It has to be somebody that doesn't have a mood disorder themselves, or?
No, not necessarily, but I think the biggest impact, whether it's ADHD or bipolar, is, the impact of interfering with their functioning. So, if it's a ADHD thing, they might, the family members or maybe a boss or something might notice that they're not getting their work done, or
Okay, so something's off.
Something like that. Yeah, something's off, or their compensatory mechanisms aren't working. And with the mood disorder, like Dara was saying, it's she never sees people in the hypomanic because they're great, they're running CEOs, but maybe they're just having an off day, etc. But maybe like they just start not acting like themselves, where they're getting into arguments more, or they're not sleeping, or they're burnt out because their brain stops working or something, or they just see like a shift where this isn't the same person that I know.
Yeah,
or like they're starting to see it affecting their relationships or their functioning. I'm sorry.
Yeah. You said something, I think you said shifting. You said something like shifting or something like just changing. And I think
that's in their personality or who they are.
Shifting, I think, is exactly what made me just like the changing and shifting. I think that's really what the family member can notice, is that pattern of change and shift. And really that, I think, is the one thing to look for, is the shifting, because that's who knows them best. And if you can just notice that there's that change, that variability is just key.
It's interesting as we're talking about this, we bring up anxiety, we bring up depression. When you think about mental health presentations, anxiety and depression are the top two. But just because you have anxiety and depression, it doesn't mean that you have bipolar. So what distinguishes ADHD and bipolar from just run-of-the-mill anxiety that I may have, not to diminish it, or run-of-the-mill depression that I may have that I should just get regular therapy for.
Do you want me to?
Sure.
Okay. So, it's really hard to distinguish it, but I think really what we're looking for is kind of exactly what I just had mentioned when I piggyback off of what you were saying about the change and the shift, I think it comes down to that pattern.
Mm-hmm.
And so when we're really looking at anxiety disorders and unipolar depression, I'm really looking at this state where it's more static and they're sitting in that depression or that anxiety. It's not, I'm not saying that it's always there, but for unipolar depression, it usually is an episode of depression where you have, whether it's a couple months, more than a couple months, 2 weeks, it happens, it occurs. You have all of the symptoms: loss of interest, depressed mood, eating more, eating less, not sleeping well or sleeping more. And once the depression episode is over, you will go back to your baseline, and then you may or may not have another episode again in your life. Mm-hmm. And then usually, if you start having reoccurring episodes of that depression, we're not really thinking about unipolar depression anymore. Yes, we can think of, there are times where you have reoccurrence, but if it becomes more than a few, that's when we're thinking, is this more of a pattern of cycling? But also with when I'm looking at whether or not it's unipolar depression versus bipolar, I'm really looking at how is someone's energy. Again, I try to ignore mood a little, and I look at energy, sleep, anxiety. And those three things will really help me figure it out, since I really think of it as, a fluctuation disorder, and sort of like almost like a, disorder of like circadian rhythm. So they're just, everything is it's out of whack. It's out of regulation. And so their sleep will be disturbed. They'll have racing thoughts, they'll have more activation, they will also have either hypoenergy, where they just can't move on certain weeks, certain days, and other days when they can't sit still. But it won't, when you're differentiating it from ADHD hyperactivity, you really can tease it out by, is this always there? Is that hyperactivity always present? Or when you're feeling good, like when you're having some good weeks, do you still feel like that? Do you feel like you can like watch a movie? Do you feel like it? And it gets really tricky when they have both. When you're looking at an ADHD with combined symptoms of ADHD, the hyperactivity, but you also have episodes of like a mixed state mood disorder. So they have it all. And so you're figuring out what's the hyperactivity from ADHD, what's part of the activation mood disorder, and what goes where. So it gets confusing.
And I think, yeah, and I was hoping maybe you can also tease out because you mentioned the anxiety a lot, and then and I feel like it's a term that gets thrown around a lot. People will come and say, "Oh, I'm anxious, I'm stressed, I'm anxious," and when you really ask about like describe your anxiety,
yes,
clinically, right? We're looking at, is it like a cognitive type of anxiety, like worrying, sense of doom, feeling on edge that something bad's going to happen, or just the phobia of sorts, right? Like whatever you're afraid of, like a fear that you might have, versus more of that physical, panic attack versus restlessness versus so yeah, I'm curious if you can speak, see more about that and how it looks in the different spectrums in ADHD, like you said.
Got it. Yes. Yeah. I love how you said that. It's so true. If we just go by what they say, and we don't really look into that, it's, we can get fooled. But when someone comes in and they say of anxiety, first, number one, I agree with you. We have to really figure out, what do they mean by that? Sometimes anxiety just means they're overwhelmed by all the time stuff. So then I'm thinking more of an ADHD. But if there is that anxiety, I'm able to tease out, there is some sort of dread, or there is some impending doom. But then I'm like, hey, is this related more to, or like intrusive thoughts, worrying? Is this related more? I'm kind of, separated the ADHD stuff, and I'm thinking, is this more part of the bipolarity type of anxiety that I'm thinking of? Or is this more of a generalized anxiety disorder? So really what I'm looking for is, again, I think about it almost like in three layers. I say like state, like how do I feel, like how do they feel right now? So what is their norm? Like, do they feel anxious that day? Have they felt anxious that whole week? Some surprisingly, sometimes they say, well, no, I don't feel that bad now, but like last week I did. And then we're able to kind of go backwards and say, well, so you don't, how do you feel now? And they really can't even recognize that anxiety from a week ago, which is interesting. And then other times, when we're talking, they feel the anxiety right then and there, and they're able to tell me it's always there. It's there even when I'm not depressed. I'm worrying. I'm a worrier. I've always been. And sometimes they'll be able to tell me that it gets much worse when I'm depressed, much worse and it goes along, coincides with my mood and lack of sleep. Really, it's how they feel right now. And then we go down to the sort of like traits, like what is their baseline tendency? So I'm really looking at first how they feel now versus how they were before, then their baseline tendencies, like where they are at their baseline, and then how things shift over time. And so for the second person, if they really, have the anxiety, it's always there and it doesn't shift even when their mood shifts, I'm thinking more of probably a generalized anxiety. I'm simplifying things. The first person I mentioned who really can't even identify, who really doesn't even, that person a week ago who was anxious, that's not how they feel, but they're just explaining them. Maybe there's more of a shifting, maybe there's more of a cyclical mood disorder. However, we have to see. A lot of times, you can have both. You can have a mood disorder with anxious features plus comorbid generalized anxiety disorder. One of the biggest comorbid disorders with bipolarity is actually social anxiety disorder, and is anxiety in general. So it's not uncommon to have, mood disorder, like a bipolar spectrum with an additional disorder. The hard part is how do you treat it? Since, there's times where most anxiety disorders by themselves do respond best to SSRI medication like Zoloft, Lexapro. So that gets to a whole nother story. But it is, I would say, really going back to the basics of how I would say pattern recognition, first state, how do you feel now compared to how you felt a week ago? Then really looking at what their baseline is like, if they can tell you how they've been and their history. So just their baseline innate tendencies, and then their pattern over time, like historical. So bringing it all together.
So, Dara, let me ask you a couple of questions that have just been rolling around in my head. Many psychiatrists are predominantly do med checks. That's what they do all day long, right?
Yep.
That's not you. Okay. You said you specialized in women's health to begin with. Okay. What got you there? Why did you do that? Because the field of psychiatry is as broad as could be, right? And you can do everything from med checks to doing what you're doing, to doing research, to doing something else. What got you into women's health?
So I think that I really just gravitated towards the field. Really, I mean, I still see men. I don't not see men, but I definitely still see men. But what happened is that I really, my specialty became ADHD. I have ADHD myself, and I started to realize a lot of patients came to me with, my meds aren't working. Why are they not working? We figured out, it was just boom, like, of the idea that they don't work during certain times of the month for females because of the sex hormones. And so that I think that was one of the big entries for me. And then it went from there to, wow, like, this isn't just during the midpoint of the month, like ovulation or the luteal phase of right before the 2 weeks before your menses, but also I would then see folks who had perimenopausal symptoms who also described ADHD meds not working. And as people may not know, perimenopause can last anywhere from, a couple months all the way to like 10 to 12 years. So that's like a range of folks. And then postmenopausal woman that's, then I have the women who are after menopause who are like, wow, do I have, ADHD or am I having cognitive decline? And so all of these women have these impairing symptoms, but no one's talking about the hormones. No one's talking about about the other aspect. And unfortunately, just like psychiatrists were never trained on certain aspects of mental health and certain things. OB-GYNs, unfortunately, did not get this training either on perimenopause, menopause. It's like a whole section of women's health was missed. We just were ignored. And so really it was a lot of my own teaching and my own, reading and learning, and made me just really interested in just figuring out these problems really for my patients, to figure out how I could help, even if it was just my, anecdotal.
Fascinating. Now, you mentioned that you had ADHD.
Mm-hmm.
Do you ever talk about that personal journey? How did you get diagnosed?
Yeah. God, let's see. So way back when my parents, I don't think it was a thing that they really realized. Although looking back, I really was a student who wouldn't shut up in class, but, I still really was a great student. I just could not stop talking. And I, really at the time didn't realize how much effort I had to put into behind the scenes to really get work done. I think I treated school like social hour the whole day, and it just wasn't even like, I don't even know what I absorbed. But that really got hard as I got older, and I was in undergrad and, biology minor and like all that stuff. And I remember, so I had a lot of anxiety, a lot of comorbid anxiety, which is definitely still not just, it was anxiety too. And so I compensated for my ADHD deficits with anxiety. And I was diagnosed, I think, when I was maybe in my teens with anxiety. However, medicated, not medicated, nothing really helped with like the focus and the ADHD and those symptoms. But I had been, I think, was it during now I'm losing track, during medical school, or during medical school, things got really hard for me. And I no longer could just play around. I was with a lot of type A students who no one wanted to talk in class and lecture. Everyone was like already like studying their anatomy. And so I saw someone older guy, psychiatrist who'd been around forever, a really great diagnostician, and mentioned the idea of ADHD. And I really dismissed it. I really thought it was just like, what? Like, this is silly. I remember thinking, maybe my brother has dyslexia. Maybe he had it. My mom always said she had dyslexia. I think I used to say my mom probably had ADHD, but at the time I wasn't even thinking like that. I went on, treated her, and then in residency, I finally, after struggling in medical school, finally saw someone else and they agreed. And I'm like, you know what? I guess it's there. And I started reading and I was in shock how much different it was than I thought. And so finally, when I started meds, it wasn't the easiest journey. Figuring out the right medication management with anxiety is hard at first. It's really, I always say you have to start slow with meds for ADHD when you have anxiety, but then you also want to optimize. So you don't want to just stay low and start slow. But anyways, and so that was my journey. And I realized that there's so many other people who are high functioning, who are in medical school or professional school, or professionals, or always thought of themselves as smart enough to get by, who do still struggle. So.
Now, you don't always need medication for ADHD.
Yeah, not at all. Right. No, okay. Not at all. And there was times, I went, and there's, definitely. I have, to be quite honest, 2 children. I was not medicated when I was pregnant. So, and that's completely, up to whatever the individual, but there are so many other, I would say skills are just as important, if not more important. Yeah.
Fascinating. Well, I usually find that our personal experiences, when you find out why somebody is in a particular area, it almost inevitably is some personal experience. They have a particular situation or condition, or they were put on a particular case and it was like, oh, look at this. It's always a fascinating story. So thank you very much for sharing your story. I want to be cognizant of the time and of everybody's desire to continue on in their day. So I'd like to kind of summarize what we've been talking about. What we'll do is I'll give Erika a minute to do that, and then Dara, I'll give you the last word, and you can summarize, and you can talk about what we've been talking about. You can talk about bipolar 2. We can talk about the documentary or anything else that you'd like, that you think is important, particularly if we haven't addressed it yet. Erika, we'll start with you.
Yeah, so thank you, Dara, for joining us and sharing all of this wonderful expertise with us. And it's certainly a very complicated, issue where, and a lot of teasing out, between what's ADHD, what's bipolar 2, or the other types of mood disorders, anxiety, and hormonal contributions on top of all of that. So the biggest takeaway, though, is I hope that, if people you don't have to struggle internally, and if you are struggling, or even if you are, seeing a psychiatrist or med management therapist, if it's not working or you're not feeling heard, speak up, or get a second opinion. You don't have to struggle, by yourself. And there are solutions, and it's nothing to be ashamed of, because, as we had talked about, there's a lot of neurotransmitter things that are going on that you can't really control, so to speak. So.
Dara?
Yeah, thank you for having me. This has been really, really great conversation. So I guess well, number one, I did want, yes, everyone to know that there is that, documentary that is airing. I have nothing to do with it. I just want everyone to be well, really just really learn about things that maybe they didn't know about themselves or family members. It's called Brainstorm, and there is a showing on Monday, March 30th. It is Bipolar Awareness Day, and there are links on the website. I think it's like basically a sliding scale of tickets of like $15 to $20. But overall, I guess what I would just want people to leave with is that really not all depression behaves the same. And if treatment isn't working for you, I really think that we really all, especially us clinicians, need to question the model and not necessarily the patient. And that really, if we're looking at bipolar spectrum, really, I think the way I think of it most is that the brain really isn't like stuck the way you think of in unipolar depression, but it's sort of shifting. And that whole shift and variability is so important to pick up on.
Great. Well, let me just, as I go through my normal close, let me just say that I personally find it absolutely fascinating when we talk to somebody that has gone through a journey of trying to understand the various aspects of a particular area, which you have. It's not just something that's taught, this is how you fix a broken bone, okay, which I'm sure has some complications. I don't want to diminish that, but nevertheless, you've gone through an incredible journey and putting things together, which is absolutely helping people, and I wanted to thank you for that. Our sponsor today is Equilibria Psychological and Consultation Services. It's an insurance-based provider whose mission is to help individuals achieve their personal potential and long-term growth by compassionately and respectfully helping clients live in balance. Visit equilibriapcs.com, equilibriapcs.com. You can look for them on Facebook, Instagram, and LinkedIn. You can also look for me on Instagram, Daniel J. Gomez 24, and on LinkedIn. Now for the disclaimer. I am not a medical professional, and I am not providing medical advice. The opinion of our speakers is solely their own. This podcast is copyrighted and cannot be reproduced without the express written consent of EPCS Management, LLC.